Evaluation of the framework, delivery, and post-insertion care. In this lecture we will discuss fitting the framework, inserting the partial denture, the clinical remount procedure, and post-insertion care. When you receive your framework from the laboratory, you should carefully evaluate the casting for adherence to the instructions. The fit of the casting on the cast should be complete and stable. Ensure there is adaptation and relief in the appropriate areas. You should also examine the cast for abrasions. This could indicate areas where the casting was forced onto the cast. Examine the framework for structural defects such as voids, excess, and porous areas. The metal should be suitably thick in places such as the marginal ridge areas of the rests. Ensure that finish lines are present and the metal is not too thin. Examine the polish. Remember, the tissue side of the maxillary does not require a high polish, as this would reduce its close adaptation. You may proceed to try the framework in the patient. Only when the framework is fully seated should one adjust the metal framework, to be in harmony with the patient's occlusion.
Several disclosing media are available for identifying interferences to seating. These items are noted in the slide. They should be applied sparingly and cleaned thoroughly between applications.
Common discrepancies are found under rests, under the shoulder of circumferential clasps, and at proximal plates. Interproximal extensions are also areas to check.
The procedure is as follows. Carefully apply disclosing to the inner surface of the framework that touches the teeth. Insert it carefully into the mouth. The partial should not be forced into place, as it may be difficult to remove. Avoid pinching the cheeks with the clasp. Once the partial is in place, apply firm pressure against the disclosing medium. Examine areas of show-through. Areas which have gone beyond the height of contour may smudge, but do not prevent seating. Once an interference has been identified, relieve with high speed. Gross interference may require a diamond, other areas a finishing burr. Clean the media off the partial and repeat the procedure. Ensure that you allow yourself time to make another impression, if you cannot seat the partial. Occasionally your impression has been distorted and the framework will not fit.
Once you have established that all rests are fully seated in their rest seats, then examine the metal framework for interference to MIP or CR. As the case may be, it is not appropriate to increase the vertical dimension with the framework, unless this was a part of the original plan. Occasionally the opposing tooth may require reduction. Using mylar shim is a good way to tell if the patient is completely closed. Verify that closure is the same both with and without the RPD. Normally the patient can tell when the occlusion is acceptable. Metal should not be ground too thin, especially at the marginal ridge, as this may result in fracture. It may also be advisable to grind the framework away from the presence of the patient. Gross adjustment requires that the framework be removed from the mouth for adjustment. Place a trial record base with light cured material and, if a distal extension partial denture, you should check for rocking. If the partial rocks with the base in place, consider the altered cast impression. If the partial does not rock, make a draw relation record with AluWax. Verify that the opposing cast is suitable, acquire a face bow, and select a tooth shade. The anatomic form of the artificial teeth generally should mirror any natural remaining teeth. You should now be able to mount master casts and prepare for tooth try-in. Occasionally, the partial denture may be fabricated to completion. It is better to perform a tooth try-in, especially in the case of the extension base or anterior partial denture. The patient should approve the appearance of the partial. Final waxing is performed and the denture is processed. Post-processing adjustments are performed, The partial denture is polished and inserted. In certain cases it is useful to preserve the face bow, and to fabricate remount casts for final occlusal adjustment at the delivery appointment or subsequent follow-up.
Typically the cast is destroyed during the process. With the ungloved finger, one should carefully inspect the acrylic for sharp spots, remaining debris from grinding, and any retained plaster. The outer surface of the acrylic should be highly polished and smooth. Characterization of the soft tissue for shade should be evaluated. Inspect the base for tissue undercuts. Carefully inspect metallic surfaces for flash acrylic. This is especially true on proximal plates and rests. Occasionally it is helpful to insert the finished prosthesis back on a duplicate master cast prior to seating in the patient. An important factor to remember: if you tried in the framework, any interference to seating at delivery is caused by the acrylic. Obtain pressure indicator paste. That is PIP, and a brush. Apply a thin coat on the tissue side of the acrylic base. All brush strokes should run in the same direction. Chill the PIP in cold water. Apply firm pressure, but do not force the RPD into place. Once seated, allow the patient to bite bilaterally on cotton rolls. Remove the RPD and gently grind the acrylic in areas where the PIP has been displaced. Only areas where the PIP film is still on the base should be adjusted. If it is stuck to the soft tissue, do not adjust. Chilling the PIP makes it less adherent to the tissue. Typical areas of pressure are noted in the slide.
Check the denture base for overextension. Pull the tissue down, out, and up. The base should not impinge on mobile tissue. The prosthesis should be stable with opening, closing and tongue movements. Once the partial denture bases have been adjusted, the occlusion should be checked. If there are two partials, adjust each partial independently of the other, against naturally occluding teeth, then together where artificial teeth oppose each other. At this point it should not be necessary to adjust the occlusion on the metal framework. Prematurities may be marked with articulating paper. It is useful to use one color for centric and another color for excursions. It is also possible to use a wax strip. See illustration. Holes in the strip indicate a prematurity. Smoothen all surfaces with wet pumice followed by acryl luster. A rag wheel is good for this, but care is used not to damage the clasp. Occasionally a clinical remount is performed, usually to facilitate occlusal adjustment. It is advisable to preserve the face bow registration. Clinically, a new MMR is made. Pickup impressions are used to make remount casts. The resulting casts are then articulated, and final occlusal adjustment is performed.
Adjusting clasps may be done with a variety of pliers. It is suggested to adjust only one clasp at a time. Care is used to adjust as the clasp could break. Cast clasps are difficult to adjust. The tip should ideally be placed into a deeper undercut area, but practically speaking clasp adjustment only provides more friction.
The patient should be instructed to place and remove the RPD so as not to bend the clasps. You should observe their ability to do this. They are instructed to keep the partial out at night, clean with a soft brush and non-abrasive paste. Soaking them in chemical antiseptic is acceptable. They should avoid using chlorine bleach. The patient should come in for 24-hour recall. Rarely a patient may not require this. Inform the patient that several periods of adjustment may be necessary, after which the adjustments will require a fee. Patient expectations can be unrealistic. If the partial was well made, adjusted, and with correct occlusion, most patients are satisfied. the patient should be given a written instruction and placed on a periodic recall appointment. There is no set time, so consider a graduated scale of increasing time intervals.